Hello everyone. DKA is an emergency case. We have to diagnose and manage it very quickly, right? And for that you have to recall all clinical things about DKA. And so I make a mnemonic for that. Hope it helps and you are able to manage it very well. I am DKA. First of all, what are the precipitants? Mnemonic I. Insulin deficiency. If you fail to take an insulin, you can get DKA. Non-compliance to insulin. Heterogenesis. Glucocorticoids and SGLT2 inhibitors, frozen drugs. Specific thing about SGLT2 inhibitors induce DKA is that it can present without marked hyperglycemia because SGLT2 inhibitors result in glucose urea at plasma concentration less than 200 milligram per deciliter. Okay. Third thing, infection, pneumonia and UTI, inflammation, pancreatitis and cholecystitis, ischemia, infarction, myocardial, cerebral and gut, intoxication, alcohol and drugs. Second important thing is clinical presentation. Again, the mnemonic is DKA. From the diabetes mellitus classic symptoms like polyuria, polydipsia, delirium and dehydration. Signs of dehydration like tachycardia, hypotension and decreased skin turgor. From K, Kussmaul respirations, rapid deep breathing due to increase anion gap metabolic acidosis. Second thing, ketogenic state. In serum, beta hydroxybutyrate is greater than acetoacetate. Two important things to be remembered. First, nitroprusside detects only acetoacetate, and second important thing is that as decay is treated, there is beta conversion of beta hydroxybutyrate to acetoacetate. So anion gap is decreased, but measured ketones is increased. Increase potassium in serum due to transcellular shift by decreased insulin and acidosis, but there is decreased total body K plus. From A, you can remember four important things: increase anion gap metabolic acidosis, abdominal symptoms like abdominal pain and nausea, vomiting, increase acetone in breath, that is responsible for fruity odor breath, and increase amylase even if no pancreatitis. How you will manage DKA? There is dehydration, right? So of course you have to do aggressive hydration, but specific points to be remembered. Again, the mnemonic is DKA. D, add dextrose to IV fluid if glucose is less than 250 milligram per deciliter and Ag is still high. K, potassium repletion, add 20 to 40 milli equivalents per liter if serum potassium less than 4.5 milli equivalents. A, main target is to achieve normal anion gap. So first of all, you continue IV insulin drip until anion gap becomes normal. 10 unit IV push insulin followed by 0.1 unit per kg per hour. Second thing, if anion gap becomes normal, then start subcutaneous insulin. Overlap IV and subcutaneous insulin for 2 to 3 hours. Replete bicarbonate if pH less than 7, and if you don't manage well, complications will develop. Mnemonic for that, AM. For A, arrhythmia due to decreased total body potassium, and M for life-threatening mucormycosis. It can present with black necrotic discharge on face. That's all. If you can't understand specific reasons behind the management of DKA, you can comment below. I would be glad to explain them. And last, don't forget the drill: like, share, and subscribe. Stay awesome.